Bismillah ar-Rahman ar-Rahim. We'll start the session right now, inshallah. It's my pleasure to introduce my beloved sister, my professor and my mentor, Professor Amani Hilal. She's going to take us through the controversies in genomic profiling. Please, Dr. Amani.
Thank you very much, Mr. Chairman, for the nice introduction. Thank you very much for your time, all my dear chairpersons. My presentation today is about the controversies in the genomic profiling. These are two cases. Both are young ladies in their 30s, no comorbidities, went to upfront left-wide local excision and sentinel lymph node, and both have T2N0 disease. With a strong ER and BR positive, HER2 negative, one with KI67 30% and the other is KI67 40%. Who can tell that they have the same disease? Who can tell that if they received chemotherapy, that I'm sure that most of us will prescribe as an adjuvant chemotherapy for such patients, who can say that they will have the same benefit from the chemotherapy, or if they are, they can all benefit from the chemotherapy. And that's why the genomic profiling have been developed. The genomic profiling analyzes the breast cancer tumor itself. It detects the personality of the tumor. So the one size doesn't fit all. And we can know the exact prognosis of the disease. And this can help the physician take our hands to choose the treatment. In other hands, to spare the patient's chemotherapy. All of the efforts are done just to spare the patients the toxicity of the chemotherapy. These are the genomic assays that are found for the use in the market. This is the NCCN guidelines with the 21 gene oncotype DX and the 70 gene MammaPrint, 50 gene Prosegna, and the 12 gene EndoProtect, and finally the breast cancer index. I'll go rapidly saying that all of these gene assays are predictive. They have been proved to be predictive. Prognostic, sorry, they are prognostic. The problem is if they are predictive or not. And only the oncotype DX that have been evidenced to be predictive in the prospective trials. And that's why the NCCN giving the high level of the evidence for the oncotype DX, mainly for the postmenopausal patients. I'll go through rapidly through the different types, mainly the first three types, the oncotype DX for the lymph node negative and the Taylor X that I'm sure that you are all familiar with. These patients with node negative, hormone receptor positive, HER2 negative, with T1C to T2N0 and high risk T1B is allowed. And the patients where they go for the 21 gene risk of the recurrence score of the 0 to 10, they received endocrinal treatment, and those with recurrence score more than 26 up to 100, they received chemotherapy. The problem is with the mid-range between 11 and 25, and these were randomized to receive either chemotherapy followed by endocrinal treatment or only endocrinal treatment. And for the whole population, there were no difference between giving endocrinal treatment or chemotherapy followed by endocrinal treatment for whole of the intention treated population. But when to go to the subgroup analysis, those who are were younger than 50 years showed some benefit from the addition of the chemotherapy between 16 and 25, not between 11 and 25. Those between 16 and 25 showed the benefit from the chemotherapy. And by the way, patients who are younger than 50 years, those with the score between 16 and 25 represented 43% of this population. And the greater treatment effect from adjuvant chemotherapy has been noted in younger women, which may be at least, and this is the explanation given to us every time, that the benefit of chemotherapy could be due to ovarian function suppression, particularly in this early trial. The ovarian function suppression was not routine given to the patients. And look to the patients with a score of 16 to 20, the addition of the chemotherapy improved the invasive disease-free survival from the 92% to 94% for 16 to 20, and from 21 to 25, the event improved from 86 to 92%. However, in the overall survival, there were no big differences between the addition of chemotherapy or not. Now, the recurrence score giving us an idea that the women younger than 50 years, they can benefit from chemotherapy. But what if we add the clinical factors? We should not ignore the clinical factors. They still present, the clinical and pathological factors. It has been found that patients with recurrence score of 16 to 20 with low clinical risk, clinical and pathological risk, showed no benefit from the addition of the chemotherapy, while those with high clinical risk have the benefit, and those with the recurrence score between 21 and 25, whether the patient has low clinical risk or high clinical risk, they get benefit, but those with high clinical risk and high genomic risk have a benefit of around 12%, which is double than those with low clinical risk. So still we have an we should have the taken into consideration the clinical factors. For those with recurrence score of 25, as you can see, 26 to 2030, there is an improvement in the invasive disease-free survival by about more than 8%. For those with 31 to 100, the improvement is more than 30%. So as the recurrence score is getting up, the benefit from chemotherapy is increasing. Not only this, for patients with recurrence score more than equal 31, anthracycline plays a crucial role in the outcome for these patients. Now I move to the patients with the lymph node positive, those with the ER and or PR more than 1%, HER2 breast cancer negative with 1 to 3 positive lymph nodes without distant metastasis. And the patients with recurrence score of 0 to 25, they were randomized again to chemotherapy followed by endocrine therapy or only by the endocrine therapy. And I shall just to be noticed that the T3 tumors represented only 5% of this group, and those with 3 lymph nodes represented only 9% of this group. And again, the chemo benefit was detected for the premenopausal patients. And the absolute invasive disease-free survival benefit with chemotherapy differs by recurrence score. Those with the low score showed a benefit of 6.9%, while those with the recurrence score of 21 to 25 showed around 10% improvement in the disease-free survival with the addition of the chemotherapy. So going back to our 2 clinical cases, one of them have a recurrence score of 13 and the other with 27. So exactly they don't have the same prognosis. And one of them was described only endocrinal treatment and the other patient described have the adjuvant chemotherapy. Again, they believe that the addition of the clinical and pathological factors add to the prognostic impact of any genetic assay test. That's why the development and validation of the recurrence score CLIN for the lymph node positive to predict the prognosis and chemotherapy benefit for hormone receptor positive, node positive breast cancer. And this is a new statistical tool that helps in patient counseling. They are using this for detecting the benefit of the adding chemotherapy so they can take the patient's opinion if she wants to receive how much the benefit that she can get from the chemotherapy. I'll go rapidly. And has been shown that the addition of the clinical factors do increase the prognostic impact of the recurrence score. For the Mama Brent, the 70 genes, and this included patients with N0 and N1 positive lymph nodes, it differs from the Oncotype DX that it has the combination of the clinical risk and the genetic risk. Besides that, it included also some HER2 positive and some triple negative breast cancer patients. The patients with went to the clinical and pathological assessment. Those with the low risk and the low genomic risk went to the endocrinal treatment. Those with the clinical risk high and genomic risk high go to the chemotherapy. The problem is with disconcordance when having high clinical, low genomic, or high genomic, low clinical, and they were again randomized to chemotherapy or no chemotherapy. The trick in the Amendment Act that they were not, it's not powered to detect the benefit of the chemotherapy. It is powered to detect the prognosis, to follow which can give you the decision, the genomic or the clinical risk. However, for the patients younger than 50 years, there is 5% chemo benefit in distant relapse-free survival at 8 years. Now, clinical outcomes. Optima, this is the third one that have been used, which is Prosegna. The Optima trial, it is the multi-center randomized double half-blind trial trying to find if there is a non-inferiority for the decision taken upon the risk categorization according to the genetic assay, or to give a chemotherapy, as this trial included high-risk patients, as I will show you. Before starting the Optima, they have a feasibility part, which is called the Optima trial, and the feasibility outcomes have been reported in 2016. Optima preliminary demonstrated significant disagreement between different MBA tumor assessments. This trial actually used the Oncotype GX and the Prosegna, both of these genetic assay methods, and they found that they are not typical, meaning that patients who have low risk with the Oncotype GX doesn't mean that they will have a low risk with the Prosegna, and I'll show you. This is what I've told. For the Optima preliminary, there were no difference between starting with the chemotherapy for patients with high risk disease, or to follow the test and they give according to the test outcome. Here is look to the one to the left. This is the recurrence score less than 25, and the Prosegna, the risk of recurrence of less than or equal 60%. Here we have 98% of the patients remained free, while on the box 2, these are the recurrence score less than 25, but with the high score with the Prosegna, and there 74% of the patients remained free. This means that there are some patients who were in the low score of the Oncotype GX, they did not do well, but they can be detected by the Prosegna test. So they take the Prosegna for the testing in the Optima trial, and the result of the Optima trial is supposed to be expected to be in the mid-2026. Addition of the CDK4/6 inhibitors to the endocrinal treatment and their relevance to the recurrence score. CDK4/6 inhibitors, we all know that they improved the progression-free survival and overall survival for the metastatic patients, and their role in the adjuvant treatment is well known. And in the Monarch E trial, it has been found that those with the low recurrence score and those with the high recurrence score, they get benefit from the addition of the abemaciclib. And these are the trials trying to find the role of the CDK4/6 inhibitors blood endocrinal treatment versus chemotherapy in the patients, so if they can neutralize the role of the chemotherapy. Now, again, not only the clinical factors, they try to have some in vitro detection of the sensitivity to the endocrinal treatment, plus the endocrinal factors, plus the biomarker change, dynamic biomarker change of the Ki-67. And we all know about the ADAPT trials, where the patients with hormone receptor positive, HER2 negative breast cancer patients went into short course of the neoadjuvant endocrinal treatment. They are, of course, they are luminal B disease, and those who responded by lowering of the Ki-67 less than 10% had the much better prognosis than those who did not respond. This is the ADAPT cycle trial, where the patients with the luminal B, high clinical risk, grade 3, and or Ki-67 more than 20%, and the BN2 or N3, and the clinically T2 to 4C with recurrence score assessed. Then the patients with the intermediate risk, it's very complicated design. and I have taken a lot of time just to understand what are they saying. يعني. Those with recurrence score less than equal 25 and Ki-67 more than 10% after the endocrinal treatment, this is an intermediate risk. Patients with recurrence score less than equal 25 and Ki-67 less than 10% but have pathological lymph node N2 and N3, this is an intermediate risk. And those with the recurrence score more than 25 and the Ki-67 dropped after neoadjuvant endocrine treatment to less than 10%, they are intermediate risk. Other groups, they went to whether low risk go to the endocrine treatment and high risk go to the chemotherapy. This group randomized to receive whether ribociclib aromatase inhibitor or the endocrinal or the chemotherapy, and the results are still not available. However, the pathological complete response, which is a sign for the sensitivity to the chemotherapy, was low in both endocrinal and chemotherapy for those who responded to the neoadjuvant endocrine treatment, meaning that we still have patients who have high risk into REN3 or larger tumors who had some endocrinal sensitivity and they might not require the use of the chemotherapy. So based on gene, what is the take-home message? Based on gene expression assay results alone, chemotherapy can safely be omitted in postmenopausal patients with 0 to 3 lymph nodes and in N0 premenopausal patients with low risk results, according to Taylor-X, RX Bonder, and MINT-ACT. Discuss chemotherapy benefit, risk regardless of the age, for recurrence score more than 30, and high risk mama print, high clinical risk. And they discuss chemo benefit and risk in patients younger than 50 years and having recurrence score more than 21, or the recurrence score 16 to 20 if they have high clinical factors, and the high risk mama print, whether low or high clinical risk. Recurrence score clin lymph node positive can help individualize risk if 1 to 3 lymph nodes were involved. Dynamic Ki-67 response to short preoperative endocrine therapy associated with endocrine responsiveness, and this is the basis of the starting the trials of the ADAPT trials. And adding CDK4/6 inhibitors to endocrinal treatment with genomic profiling scores could help in equalizing the benefit of chemotherapy in high-risk subgroups. Who knows, it might be found in the ongoing trials. The value of the genomic profiling is still confined up to this moment to the N0 and N1 disease, and we don't have still an idea about the N2 and N3 disease. It's still unknown whether the beneficial effect of chemotherapy in premenopausal patients due to ovarian function suppression, and there is some trial is ongoing and we are waiting for the results. Adding clinical and pathological factors to the genomic scores could increase the prognostic and the clinical utility of this genomic profiling test. Thank you very much.
شكرا دكتورة إيمان هلال على ال eminent presentation and fruitful presentations and very individualized يعني precision medicine in breast cancer. وإن شاء الله نخلي الدسكشن بعد السيشن يعني في نهاية السيشن إن شاء الله. دلوقتي إن شاء الله مع توبكس مع دكتور مي عيسى neoadjuvant therapy current landscape and the future horizon in ER positive breast cancer.
Thanks for this nice presentation, and I would like to thank Dr. Amani Lel for this great opportunity. Our talk about neoadjuvant therapy, current landscape, and future horizons for ER positive, HER2 negative early breast cancer. This is the overview of the early breast cancer ESMO guidelines. As we know, there is a clear benefit of a neoadjuvant treatment in HER2 positive triple negative, but there is a debatable area in hormone receptor positive HER2 negative in a neoadjuvant therapy versus adjuvant treatment. According to risk of distant recurrence, according to tumor grade, there is a high grade with risk of distant recurrence, while also in lymph node involvement. Role of neoadjuvant therapy, downsizing tumors to facilitate complete surgical resection, increase the breast conservation rate, in vivo testing of the efficacy of systemic treatment, and there is questions regarding improvement of disease-free survival and the overall survival.
Historically, there is trials of National Surgical Adjuvant Breast and Bowel Project B18 trial that was designed to answer these questions regarding preoperative versus post-operative chemotherapy. And this trial, there is no difference in disease-free survival and the overall survival between preoperative and post-operative chemo. There is a best conservative surgery rate was greater in the preoperative chemo group, and the pathological CR rate was 13%. However, no significant difference in survival was observed. What about survival according to response type? Those with residual disease after neoadjuvant treatment had a worse outcome rather than who had pathological CR after neoadjuvant therapy. The rule, this was supported by early breast cancer trialist collaborative group meta-analysis across 10 trials that was neoadjuvant versus adjuvant treatment, also indicated no survival advantage for administering the same chemotherapy before surgery rather than after, with reducing of distant recurrent rate and overall mortality rate. What about B27 study designed two questions to answer adding of taxanes in the neoadjuvant settings, neoadjuvant chemo and surgery to split or not to split. The results showed that addition of docetaxel to the preoperative chemo improvement of the pathological CR rate, no significant improvement of disease-free survival or overall survival, and there is a trend in relapse-free survival with the full neoadjuvant regimen, for which using the standard 6 to 8 sequential anthracycline taxanes adjuvant regimen in the 4AC4 docetaxel in an NCCN guidelines that was added in 2016. Absolute indication of a neoadjuvant chemo inflammatory breast cancer, more than or equal N2 disease, T3 to 4 tumors, and the larger primary tumor relative to breast size in patient who is otherwise candidate for breast conservative surgery, including even T2 and 0 tumors, which is that sensitivity of the luminal breast cancer to chemotherapy is comparatively lower than that observed in cases of HER2 amplification or the basal-like subtype. The pathological CR rates in luminal cancer generally range from less than 10% to less than 30%, with a high level of estrogen receptor expression, which is considered a negative factor for chemotherapy response. However, pathological CR occurs frequently in young patients and with high-grade tumors. In Cortazar meta-analysis showed that in pathological rates was more in HER2 positive than triple negative, but low in luminal types, hormone receptor positive, with high-grade tumors more than grade 1 or 2 tumors. What about dose-dense regimen? Adjuvant, a phase 3 trial, CALGB C9741, investigated the benefit of a dose-dense regimen in the adjuvant setting for breast cancer with lymph node involvement. It demonstrated the high-risk population, including the ER-positive subpopulation, with improvement of survival and disease-free with dose-dense therapy. Is there any regarding neoadjuvant? There is no full randomized trials for dose-dense therapy in hormone receptor-positive HER2 negative. Supported by the early breast cancer trialist group meta-analysis of 25 trials that showed that in neoadjuvant versus adjuvant treatment in a dose-dense strategy associated with a reduction of post recurrence and the breast cancer mortality, with no discrepancy between the ER negative and the ER positive. Another trial, which is called GEM2 trial, that demonstrating the benefit of a dose-dense in form of disease-free survival and overall survival benefit. Another question regarding de-escalation strategy in hormone receptor HER2 negative. Why should we adding neoadjuvant endocrine therapy could be given to downstage tumor prior to surgery? Neoadjuvant endocrine treatment and chemotherapy have a similar rate of clinical radiological response and the rate of breast conservative surgery, but with lower rates of toxicity. AI is superior to tamoxifen in terms of clinical radiological and rates of breast conservative surgery. Longer duration of neoadjuvant endocrine treatment, allowing for higher rates of pathological CR and breast conservative surgery, which will go forward to study more on gain insights into the biology of the tumors regarding the biomarkers response resistance to treatment. And this was supported by a systemic review of meta-analysis of 20 randomized controlled trials through 2015, which showed that AI showed significantly high rate of a clinical response and the radiological response, and also with breast conservative surgery versus tamoxifen. But in arm of chemotherapy plus endocrine treatment versus endocrine, there is a more radiological or favoring of a radiological response with higher rate of pathological CR. As Dr. Amani said before about the guidelines that recommended the biomarker testing of gene expression assay to guidance of adjuvant treatment regarding omission of a chemotherapy or de-escalating strategy, and this was added in 2022 ASCO guidelines for biomarkers like oncotype DX, Prosigna, Mamaprint in guiding of us to de-escalating strategy. What about the neoadjuvant settings? The role of molecular signatures in the neoadjuvant setting is not firmly established and should not be recommended in routine practice today. However, consistent data indicate better response to neoadjuvant chemotherapy with the high recurrence score. In retrospective analysis of postmenopausal patients with ER positive HER2 negative who received 6 months of a neoadjuvant letrozole and breast surgery in the NEWS trial, there is a higher proportion of patients who had recurrence score less than 18 had a clinical response rather than patients who had recurrence score more than 31. Phase 3 alternate study, which is a randomized study investigating neoadjuvant anastrozole versus fulvestrant versus anastrozole plus fulvestrant in postmenopausal women with ER positive HER2 negative, that with 24 weeks of a neoadjuvant followed by surgery with Ki-67 more than 10%, and testing the Ki-67 after week 4 or week 12. The patient who had not responding to treatment with the Ki-67 less than 10% go for neoadjuvant chemo group and then followed by surgery. The primary endpoint of this study, which is endocrine sensitive disease rate, which equal pathological CR plus preoperative endocrine prognostic index with 0 to 1. And this study showed that this primary endpoint equivalent to the 3 arms, and also pathological CR was equivalent with no pathological CR or less than in the arm of a combination therapy. In patients who had received the salvage neoadjuvant chemotherapy with residual cancer burden, their in intention to treat population, pathological CR was very low benefit of 4.8% only. And this is Dr. Amani said this is the study about adapt hormone receptor positive HER2 negative, and it was difficult to us to understand the study design, which is endocrine response rates, which assessing the prognosis with testing the oncotype DX with 3 weeks endocrine treatment, followed by assessment of the efficacy by surgery or biopsy, and testing Ki-67. Patients who had low risk, 0 to 11 of a recurrence score, no benefit to add the chemotherapy and go for endocrine treatment only, but risk assessment in intermediate and with proliferation response, go for chemotherapy or endocrine treatment. Prognostic effect of an endocrine treatment on invasive disease-free survival, as we see that early Ki-67 response strongly predict excellent 5 years of an invasive disease-free survival, as in the Ki-67, if dropped, it is an indicator for endocrine treatment sensitive, and this was holding across the aging of all menopausal group. Also, in age subgroups of endocrine response and gene expression testing, there is equivalent in the 2 age subgroups of endocrine treatment responders. And also in endocrine responding with Ki-67 less than 10% or equal to 10%, it's more benefit in patients who are postmenopausal patients with AI. Also in the premenopausal with the EI plus the ovarian function suppression, there is a benefit in these 2 arms. What about the patient in age subgroups for patients that not responding to endocrine treatment and go for chemotherapy? As we see in these curves, that non-responders, even with chemotherapy, have somewhat lowered distant disease-free survival, that the endocrine treatment response reflects intrinsic tumor biology, not just the treatment choice that we give to the patient. What about pathological CR in the chemotherapy part? Patient who higher recurrence score and poor endocrine treatment response, there's had a greater chemo benefit in pathological CR of 21.4% with a significantly p-value. What about the future considerations? Adding CDK4/6 inhibitors in adjuvant settings, it is approved for high-risk early breast cancer. What about adding CDK inhibitors in a new adjuvant setting? There are many trials in the form of the Baheya study, which is a phase 2 trial randomized for letrozole palbociclib versus letrozole alone with no significant was observed in a clinical response and or progression. In the new PAL study, that's another phase 2 trial that comparing between letrozole palbociclib versus chemotherapy with no significant pathological CR, histological response or clinical response, but there is a notice of about the BEPI scoring was achieved in 17.6% in the endocrine treatment arm versus the chemotherapy arm. Another investigating trial about ribociclib in Coraline study, which investigating ribociclib plus letrozole versus chemo in human BER positive HER2 negative with BAM 50 assessment in a high risk of a recurrence risk group. After 24 weeks of a new adjuvant treatment, the rate of conversion to low risk was similar for the ribociclib and chemo arms, suggesting that the molecular downstaging is very possible with ribociclib and letrozole. New Monarch study investigating neoadjuvant abemaciclib, anastrozole, and abemaciclib plus anastrozole in hormone receptor positive HER2 negative breast cancer. And primary endpoint with the percent change in Ki-67 from baseline to 2 weeks of treatment. This study showed that Ki-67 suppression was 92% with the abema versus 69% with the EI alone, strongly early anti-proliferative effect, improving complete cell cycle arrest. Another study, which is called Feline, that investigating neoadjuvant ribociclib plus letrozole versus placebo plus letrozole, and this study assess Ki-67 response and the PEPI scoring. Ki-67 was suppressed very high, but no difference in the PEPI 0. Ribo suppressed proliferation, but with no pathological CR gain. And this, Dr. Amani said before, adapt study design, which is another design for the adapt, which is called the adapt cycle, adding ribociclib in the arm in the intermediate recurrence score versus chemotherapy, and still waiting results of this study. What about another targeted agents like trastuzumab deruxtecan plus or minus anastrozole that in HER2 was being approved in a metastatic setting of the hormone receptor positive? What about adding in a new adjuvant? And this is a study this ongoing, still ongoing and waiting for the results with primary endpoint pathological CR. Another study designed for iSpy 2.2, adding dato-DXd plus durvalumab 4 cycles, followed by standard of care therapy with primary endpoint pathological CR, dato-DXd, which is an which is ADC with anti-TROP2 antibody linked to topoisomerase 1 inhibitor, and waiting results. Also in Keynote 756, as we know that the benefit of pembrolizumab in triple negative, it was this study designed for adding pembrolizumab in new adjuvant in hormone receptor positive HER2 negative, and still waiting results of it. But the initial results was showed that enhancing the pathological CR rate in patients with grade 3 node positive T3 and T4 ER positive HER2 negative tumors. Also, oral SERDs of ESR1 mutation in ongoing study in the new adjuvant treatment. And this is my conclusion, and thank you.
Thank you. Thank you, Dr. May, for your comprehensive hot topic. A lot of questions in this subject could be raised. And next speaker, Dr. Abdelhamid Fouad. Welcome, Dr. Abdelhamid, and he's talk about ADC in HER positive, ADC in hormone positive HER2 negative between present and future. Dr. Abdelhamid.
السلام عليكم ورحمة الله. شكرا دكتور خالد على المقدمة. والنهارده إن شاء الله I will cover a topic على ال ADC في الهرمون receptor positive HER2 negative metastatic breast cancer. I think إن إحنا في الإيرا بتاع ال ADC يعني كل أو كتير من ال research في different malignancy topics investigating the role of ADC, and they prove efficacy, improving results and survival rates. In the coming 15 minutes, we will cover the current landscape in this type of disease and the emerging horizons of research. This is my disclosure. Let's skip this. As we all know that hormone receptor positive represent most of the breast cancer. It's almost 70% of breast cancer subtypes, and it is associated with HER2 negative. Both are about 73. Other molecular subtypes is triple negative, basal-like, and hormone receptor negative, HER2 positive, or triple positive. The treatment algorithm for a very long time for this hormone receptor positive HER2 negative metastatic cases was for a very long time starting with endocrine treatment, either monotherapy or in combination with the CDK4/6 inhibitor in most patients, and restricting chemotherapy in patients with visceral crisis, as we can see. And after progression, usually we trying to avoid chemotherapy again, going to a second-line hormonal treatment, or if the patient has a driver mutation like PIK3A or BRCA mutation. And after that, finally, we go again to chemotherapy. And different chemotherapy subtypes, maximum benefit is about 4 to 6 months progression-free survival when used in this disease area. And if we can remember this picture, for a very long time, HER2 start with about 15% almost from breast cancer subtypes, and the other subtypes is HER2 negative, HER2 positive, I mean, and the other subtypes are HER2 negative. But this is changing through different trials evaluating the role of ADCs in HER2 negative and subclassified to HER2 negative to HER2 low and ultra low and HER2 negative. And the future will be ending like this. We start with a small subcategory HER2 positive, and the rest of breast cancer is HER2 negative. And we expect in the near future that HER2 low and ultra low will be the most of the breast cancer subtypes. From this is the old paradigm, and this is the new paradigm. It is represent HER2 low, represent about 60% of the HER2 negative cases, and these subtypes are targetable by ADCs. As I mentioned, before the era of ADCs, the HER2 low subtype is usually treated by hormonal, followed by chemotherapy, and in most of the data that we have, that the progression-free survival is usually about 4 months in the best medication that we have. Then came the era of ADCs, and it was investigated in this disease area, and to revise, the ADC is the antibody-drug conjugate, target a receptor on the tumor cell, and it is composed of an antibody antibody, a linker, and a payload, which is the chemotherapy drug. And the mechanism of ADCs start by binding to specific receptor or target, followed by internalization of the antibody with the payload, then release of the payload inside the tumor lead to antibody cytotoxicity, chemotherapy cytotoxicity, and lead to cell death. And the new generation of ADCs has an extra effect, which is the bystander effect. When the tumor cells is killed and these payloads are released in the tumor environment, it can internalize without an antibody to the other tumor cells, leading to added cytotoxicity, which is called bystander effect. So the mechanism and the efficacy of the antibody drug conjugates in general depend on the antigen target and the drug antibody ratio, and the payload, which cleavable or not cleavable, and if it has bystander effect or not. Nowadays, we have 3 drugs are approved in hormone receptor positive HER2-low, the trastuzumab deruxtecan, and it approved for HER2-low and ultra-low, the SG or sacituzumab govitecan, and it has no biomarker specific. It can be given to any hormone receptor or hormone negative, HER2 negative. And recently, the deruxtecan also was approved with no biomarker specific. The evidence that we have, trastuzumab deruxtecan was approved based on DESTINY-04 study in metastatic breast cancer hormone receptor positive HER2-low, progressed on endocrine treatment and chemotherapy. And patients were randomized to receive T-DXd versus physician choice of chemotherapy, and the primary endpoint was PFS. And this is the result of the study. It is positive result in intent to treat population on the right side, and also a specific subgroup analysis in hormone receptor positive subtype. This is also the overall survival results. It's also positive. The second trial that investigated the role of SG is the TROPICS-2 trial. It is a phase 3 trial evaluating patients with hormone receptor positive, HER2 negative, either HER2-low or ultra-low or pure negative, in patients with progressed after hormone receptor and chemotherapy, to SG versus, again, physician choice of treatment. This trial also was a positive trial. The primary endpoint was progression-free survival, as we can see the results, and was at 6 months, 12 months, 18 months is still showing superiority to SG. And this is the overall survival result of the trial. The third trial for DXD, the Tropion Breast 01 trial, it is again a phase 3 trial. The same design almost, hormone receptor positive, HER2 negative, metastatic breast cancer progressed on hormonal treatment and also chemotherapy. PFS of the trial, again, this is the results of the trial. It is a positive trial. So we have 3 new drugs in this disease area, but we have some challenges and limitations. Number 1 is the toxicity of the ADCs. It has specific toxicity. The physician should be trained how to detect and how to manage. Also, resistance mechanism also occur. We have to understand the resistance mechanism, and this guide further research. Patient selection, these patients need a specific biomarker like HER2-low or ultra-low in T-DXd, or no biomarker specific. The cost and accessibility of the drug, which is an important topic to be discussed with the patient. And the specific toxicity of each drug is summarized in this table. Trastuzumab, as we all know, has specific lung toxicity, interstitial lung disease, and embryo-fetal toxicity. SG, because the payload is SN like irinotecan, neutropenia and diarrhea, and deruxtecan stomatitis is the main toxicity from it. Now the treatment algorithm in this area, hormone receptor positive, HER2 negative metastatic breast cancer, first line is still hormone receptor plus CDK plus or minus. And if progressed, if the patient has a driver mutation like ESR1 or PI3K, should be received. And later on, we can introduce the TDXD in the after progression of hormonal treatment and chemotherapy, and DATO and SG if the patient progresses on chemotherapy, even if he is pure HER2 negative. But after these achievements, still we gain improvement in progression-free survival. But again, with still progression-free survival is still limited. After CDK inhibitor, further research is still needed, and aiming to improve this disease area, because they represent about, as I mentioned, about 70% of breast cancer patients. Near future trials, they are trying to combine, as Dr. Amai mentioned, in the neoadjuvant or in the metastatic setting, ADCs with other agents, or giving ADCs before chemotherapy, like the Destiny 06. They are trying to they try to investigate the efficacy of TDXD in this patient category in metastatic hormone receptor positive HER2 low or ultra low in chemotherapy naive. After progression to hormonal treatment only, they started TDXD versus physician choice of chemotherapy. And it is a positive trial. It in the intent to treat in the HER2 low and an ultra low also. Based on this trial, after gaining FDA approval, we can start ADC, specifically trastuzumab deruxtecan, after progression to hormonal treatment without starting chemotherapy. This is a combination in this trial, the Destiny 08. They combine TDXD with different agents like chemotherapy, like IO plus chemotherapy, like hormonal treatment, like fulvestrant, and thinking if this will potentiate the efficacy of ADCs and can overcome the drug resistance or the resistance to treatment, aiming to improve more the progression-free survival and overall survival. Another important point is ADCs will work if we give an ADC after an ADC sequencing of more than one ADC. And this trial also, it includes patients, 68 patients we received more than 2 ADCs. And as we can see, PFS after the first ADC is about 7.5 months. The second ADC, 2.5 months. It's much lower. And they concluded that the cross-resistance, there is cross-resistance if we use an ADC with the same antibody target. It gives a hint for future research. If we will do a larger trials, it's better if we will sequence ADC to use the second ADC targeting another target. This is another strategy in the future. And also we have emerging other therapies in the pipeline, like trastuzumab deruxtecan. It is investigated in a phase 1 trial in metastatic breast cancer, either HER2 positive or HER2 low and hormone positive, and HER2 triple negative. In HER2 low hormone receptor negative, it includes 32 patients, and as we can see the waterfall plot, we have objective response rate about 28% of heavily pretreated patients. These patients receive about 6 lines of systemic treatments in hormone positive, 7 lines of systemic treatments, and it is promising molecule. Another molecule is distimab vedotin. It's also investigated in a phase 1 trial, and also the results are promising. Another molecule is zenocutuzumab. It is again another ADT, and also has promising results in hormone receptor positive HER2 low, and another ongoing phase 1 and phase 2 and phase 3 trials investigating different classes of ADCs with different targets. As we can see in this disease area, we are waiting for these results. Future potential futures innovations need to research more for more new antigen targets, use genetic engineering for making more smart ADCs with better linker and better payloads that are more potent, less toxic, with a better bystander effect, which is a very important in the mode of action. trying to combine ADCs with IOs, endocrine therapy, CDK4/6, and chemotherapy to overcome resistance that occur, and shifting ADCs earlier in the treatment setting in future trials, in the first-line treatment or in adjuvant or neoadjuvant, and improving delivery by minimizing resistance and managing toxicity. My takeaway message that nowadays we are in the era of ADCs. ADCs is a game-changing player in the hormone receptor positive HER2-low metastatic breast cancer. We have approvals that fill important gaps. First is the TDXD, and it is used in HER2-low or ultra-low hormone receptor positive in the first or second line based on the approvals, and Dato-DXd and SG with no specific biomarker, even if the patient is pure hormone receptor negative and HER2 negative. Also, it works in hormone receptor positive and HER2 low. Many promising agents in the pipeline waiting the results of the trials. It's remain unclear to sequence one ADC after the other ADC, but it is an idea that needs further research, and the future to shift to combine better patient selection and better and another targets to be targets. Thank you for your attention.
شكرا دكتور عبد الحميد for this nice presentation. طبعا زودت حيرتنا طبعا دلوقتي بنستخدم الاي دي سي دلوقتي كمان شويه في الادجuvant او النيو ادجuvant versus الامين ثيرابي، فاحنا واقعين في حيره طبعا. طبعا كل شويه الابديتس بتطلع كتير، فاحنا ما عندناش ملاحقين حقيقه يعني. شكرا دكتور عبد الحميد. وموف ناو فور next speaker دكتور هبه علي will talk about optimization of management of PC in elderly patient.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Amini for giving me the chance to participate in this great event. Thank you for the chairpersons and for all the attendees. I'll talk today about optimization of management of breast cancer in elderly patients. Our agenda includes introduction, challenges in management of breast cancer in elderly patients, geriatric clinical assessment, treatment algorithm for elderly patients, and finally take-home message. As we all know that breast cancer is the most frequently diagnosed cancer and the leading cause of cancer deaths among women worldwide, representing about 1 in 4 cancer cases and 1 in 6 cancer deaths globally. Breast cancer in elderly patients is considered a major health problem, and its incidence increases with age. About 45% of breast cancer cases are diagnosed above the age of 65. Despite the absence of consensus of the definition of older patient, there is growing tendency to consider that the cutoff age is at 70 years. And according to the WHO, a person is considered old from the age of 60. Most studies demonstrate that older patients are more likely to have hormone receptor positive, HER2 negative, lower risk tumor histology disease, with lower incidence and even no lymph node involvement, which generally carries a more favorable prognosis. Scientific societies have generally considered the cancer in elderly patients as less aggressive as compared to younger women, and alternative approaches lead to over or most likely under treatment in many cases. Elderly patients demonstrate significant clinical heterogeneity, necessitating the careful consideration for such factors, especially for biological age, that reflects how the patient functional physically and socially properly in the environment. Associated comorbidities, functional status, and life expectancy when tailoring treatment strategies. A comprehensive geriatric assessment can play a pivotal role in stratifying patients into fit, pre-frail, and frail categories, enabling us to select the most appropriate treatment option for each group. What are the challenges in management in breast cancer in elderly patients? Clinical heterogeneity among elderly patients, lack of representation in clinical trials and guidelines, and lack of routine geriatric assessment. So, consideration in management in breast cancer in elderly patients, we should take in consideration the breast cancer characteristics, patient's overall health, especially for the biological age rather than the chronological age, patient preference, patient lifestyle and goals, and associated comorbidities. Thus, individualizing therapy can help to avoid undertreatment or overtreatment. Again, key patient consideration for oncologists when treating older patients include pre-treatment evaluation, including comorbidities and geriatric syndrome and social support, plurality, and understanding patient goal for treatment, thus maximizing the quality of life. Best practice for geriatric clinical assessment. A comprehensive geriatric assessment is recommended for all older patients above 70 to identify who might benefit from active therapies. Utilizing the geriatric A screening tool and comprehensive geriatric assessment with a special consideration for comorbidities and polypharmacy to optimize therapy and reduce toxicity. Here is the geriatric age geriatric screening tool that includes several items, including nutrition, mobility, depression, dementia, polypharmacy, health status, and age. Each item is given a score for each possible answer. This score ranges from 0 to 17, with cutoff value 14 or less indicates impairment of or frailty. If the patient is frail, next step is to perform a comprehensive geriatric assessment. Components of the comprehensive geriatric assessment includes several domains, namely functional status, comorbidities, cognition, nutrition, psychological status, social circumstances, polypharmacy, and clinical syndrome. For each domain, we should identify if there is deficit or not. If detectable deficit, we should correct this deficit using special interventions. Here is a brief comprehensive geriatric assessment template or form, just to show you. It's very long, but I try to show in one slide. Patient can be classified into healthy, vulnerable, or frail patient. Healthy patients tolerate standard treatment and gain benefit equivalent to that of younger patients less than 65 years old. Vulnerable patients are less tolerant to standard treatment, but amenable to intervention on modifiable areas of vulnerability, while frail patients present impairment in multiple physiological systems, often, but not exclusively age-related. As for us, what should we do? There is a checklist for geriatric assessment that should be performed on the clinical setting. Functional status and mobility, comorbidities and medications, cognition and mood, nutrition, and social support. This slide is very important, should be applied for every type of cancer in elderly patients. The treatment algorithm for evaluation and treatment for elderly patients with breast cancer includes breast cancer who are age 70 and more should undergo geriatric age screening tool. Those who had score more than 14 considered as fit patient and should receive standard or tailored treatment. If the patient is frail, who had 14 or less on the geriatric age score, we should perform a comprehensive geriatric assessment to identify problem. If this problem can be corrected by special intervention and the problem is solved, we should offer the patient standard or tailored treatment. If the patient is not susceptible for intervention, they are offered palliative care. This will be applied for each type of cancer in elderly patients. Starting by therapy for hormone receptor positive HER2 negative in early breast cancer, as in young fit patient, early operable disease with no indication for chemotherapy underwent upfront surgery followed by adjuvant treatment with or without chemotherapy, while patients who had clear indication for chemotherapy including large T4 tumors or clinical N2 and N3 disease, lymph nodes, high-grade disease, preferably should be offered neoadjuvant chemotherapy followed by surgery and post-neoadjuvant treatment. However, patients who are unfit for chemotherapy or have unclear indication for chemotherapy, which represent high proportion of our elderly patient, receive neoadjuvant hormonal treatment. Patients who had downstaging of their disease undergo surgery, while patients who did not receive, who did not respond properly to endocrine therapy, either underwent surgery followed by adjuvant treatment, or if still became fit for chemotherapy, offered the neoadjuvant chemotherapy followed by surgery and post-neoadjuvant treatment. Moving to treatment for hormone receptor positive HER2 negative in the metastatic setting, CDK4/6 inhibitors plus endocrine therapy is the standard initial treatment for newly diagnosed patients in the metastatic setting, even in the second-line treatment. It's important to monitor adverse effects closely for older patients receiving any systemic therapy. CDK4/6 inhibitors can cause low blood counts, fatigue, and other adverse effects, which older patients may be more susceptible to. Doses might be adjusted or extra monitoring employed to ensure treatment remains tolerable. How we monitor CDK4 inhibitors? For abemaciclib, the most common adverse effects include neutropenia, fatigue, diarrhea, and nausea. We should monitor it with CBC and liver function test, with a special consideration for VTE and hepatotoxicity. Valbociclib, neutropenia and fatigue is most common, should be monitored by CBC. While for ribociclib, neutropenia and fatigue is more prominent, should be monitored by CBC, liver function test, ECG, and electrolyte, with a special consideration for QT interval prolongation and hepatotoxicity. During therapy, patient and the clinician should check in at each step regarding having a frank discussion about what to expect from the treatment, carefully consider treatment, and then monitor how the patient is coping once the therapy begins, using supportive care as additional measures if needed. Special consideration should be given and properly choosing the regimen that offers the best chance for cancer control with least disruption to the patient's health and daily life. Moving to therapeutic options and recommendation for elderly patients with HER2 positive breast cancer. Starting by the neoadjuvant setting, bertuzumab in addition to Herceptin with weekly paclitaxel for 12 weeks is advisable to this patient. Bertuzumab in addition to Herceptin is considered safe and effective. Patient who had residual disease in fit older patient, TDM1 is offered for 14 cycles. If there is complete pathological response, Herceptin is offered 1 year, unless there is toxicities or cardiovascular risk. 1 year is downstage to 6 months only. In adjuvant setting, if the patient is fit, anthracycline for 4 cycles followed by weekly paclitaxel for 12 weeks in addition to Herceptin is an option. However, this category is very small percentage. If anthracycline is contraindicated, paclitaxel in addition to carboplatin for 4 cycles with GCSF and Herceptin is recommended. In lower risk tumors, only weekly paclitaxel 12 weeks in addition to Herceptin is offered. In unfit patients with low risk patients with hormone receptor positive, aromatase inhibitor in addition to Herceptin is recommended. Again, for adjuvant, Herceptin is recommended for 1 year. Consider 6 months in cases of cardiovascular risk toxicities and low-risk patients. Moving to the metastatic setting, first line for fit patients, pertuzumab plus Herceptin, in addition to weekly paclitaxel or paclitaxel every 21 days, in addition to G-CSF, is recommended. First line for unfit or hormone and hormone receptor positive, consider pertuzumab, Herceptin, and aromatase inhibitor. Second line for fit patient, trastuzumab deruxtecan is recommended. Third line for fit patient, Herceptin and tocatinib are options. What about therapy for triple negative early breast cancer? Multimodal treatment is considered the standard of care. In early stage operable cases, surgery should be underwent upfrontly, followed by adjuvant chemotherapy similar to the neoadjuvant setting. With clinical stage T1B, lymph node negative, and T1C, lymph node negative, should be offered neoadjuvant chemotherapy followed by surgery. We should notice here in neoadjuvant setting, dose-dense chemotherapy is not recommended at all. And given cardiac complications and comorbidities in this elderly group, anthracycline should be omitted and to give less toxic chemotherapy regimens. Patients who had no pathological complete response with BRCA1 and 2 wild type, capecitabine is recommended for them, while BRCA1 and 2 mutant olaparib for 1 year is offered. What about clinical T2 or higher with lymph node positive disease? In the era of immunotherapy, pembrolizumab, there is no high data that recommended its use in elderly group, especially in clinical trials where immunotherapy given to patient in triple negative. There is low percentage of patients in the elderly group who are included in these trials, so there is no special recommendation for using of immunotherapy in the elderly. Metastatic triple negative breast cancer in elderly patient is usually best treated with single agent sequential therapy based on the toxicity profile of the agent and the physician's choice. Finally, take-home message: clinicians should offer clinical trial participation to all fit older women with breast cancer. Elderly patients with breast cancer require personalized approach, comprehensive assessment for virality and comorbidities, tailored treatment regimens, balancing between efficacy, side effects, and quality of life, with close monitoring and proactive supportive care to help maintain therapy and improve outcome. Thank you.
شكرا دكتورة. شكرا دكتورة for this nice presentation. And now it is a case presentation by Dr. Ahmed Chiha.
Good afternoon, dear professors and colleagues. Many thanks to Professor Aman Hilal for this opportunity. I'm Ahmed Chiha, medical oncology specialist at Baheya Foundation and the Maadi Armed Forces Medical Complex. So I'm going to present a case of a female patient, 45 years old, married with 2 offspring. Youngest one is 15 years old, premenopausal, no medical history of chronic disease, no special habits, and a negative family history. Complained from right breast lump 2 months ago. She came at Baheya for medical advice. By clinical examination, she was initially clinical T2N0. Sonomammography revealed the right breast lesion, about 3.5 centimeters, caused by RAD4 with no suspicious lymph node. Donor-guided biopsy was done, and the pathology revealed invasive duct carcinoma grade 2. By immunohistochemistry, she was luminal type HER2 negative Ki6735. Patient was referred then to MDT at Baheya that decided to go for upfront wide local excision plus sentinel lymph node biopsy. And the histopathological examination was invasive duct carcinoma grade 2, pre-surgical margins. It was pathological T2N1 over 5 by sentinel lymph node biopsy. So as regards the adjuvant chemotherapy, what do you prefer for this patient? Either docetaxel, cyclophosphamide, or anthracycline-based regimens. And once chemotherapy is considered, the next step is a careful risk-benefit balance, aiming at choosing which specific regimen to offer. Although anthracyclines have long been one of the mainstays in the treatment of breast cancer, but in the last years, the rule has been challenged, and with the concerns regarding anthracycline-related toxicity, the emergence of alternative active cytotoxic agents, as well as targeted strategies, has progressively fueled the debate about de-escalation of anthracycline. And when we are talking about the anthracycline de-escalation, we have a question: is it time to de-escalate anthracycline, especially in treatment of those subgroup of patients, or not? And in order to properly and critically address this high priority clinical issue, the following questions need to be answered. The first one: are the data supporting the use of anthracycline no longer appropriate in the landscape of early breast cancer treatment? The second one: are the data supporting chemotherapy de-escalation solid enough to enable us to safely withhold anthracycline? The third one: are concerns regarding anthracycline long-term safety justified with cumulative doses reached with the recent regimens? And guess what? The answers for the three questions are no. Now we will going to review some data that support the role of anthracycline in treatment of early breast cancer patients. We have a meta-analysis by the Early Breast Cancer Trialists Collaborative Group in 1998. It showed a 20 to 25% proportional reduction in breast cancer mortality with CMF or with 4 cycles of AC compared with no chemotherapy. Adding taxane also to anthracycline containing chemotherapy or substantially increasing the cumulative dose of anthracycline reduces breast cancer mortality by a further 10 to 15%. And the most recent update of this meta-analysis, it demonstrated a 15% proportional reduction and a 2.5% absolute reduction at 10 years in the risk of invasive recurrence for anthracycline taxane combination versus taxane-based regimen. In 2012, Early Breast Cancer Trialists Collaborative Group individual patient meta-analysis has demonstrated that anthracycline-based regimens are superior to no adjuvant chemotherapy. Also, it was superior to chemotherapy regimens that contain neither anthracycline nor taxane, and anthracycline-taxane combination is superior to anthracycline-based chemotherapy. We have the ABC trials that failed to demonstrate the non-inferiority of 6 courses of taxane-based chemotherapy over anthracycline-taxane combination. Rather, an improvement of invasive disease-free survival was demonstrated for the anthracycline-based combination. As we can see in the diagram, the 5 years invasive disease-free survival was 90.7% versus 88.2% for taxane, anthracycline, and TC respectively, with a statistically significant difference, of course. This analysis shows the benefit of taxane anthracycline was more evident in the studies that had longer follow-up times for the patients with hormone receptor negative disease and who had the highest number of lymph node infiltration. Also, the analysis helped establish anthracycline and taxane combination as a standard for adjuvant treatment in this situation. Similarly, there is a pooled analysis of West German study Plan B and ABC trials and Hellenic Oncology Research Group trials. And from the table, we can see that out of the 3 studies, only Plan B and ABC trials included patients without infiltrated lymph node. And the difference in survival, even for those who have lymph nodal infiltration, was not statistically significant. And the non-inferiority of the taxanes versus anthracycline taxane couldn't be proved. Why we are raising the issue of anthracycline de-escalation? Because of its toxicity. Despite their ability to improve survival for women with early breast cancer, anthracyclines can result in either short-term toxicity like nausea, neutropenia, and hair loss. And so, rare but important long-term toxicities include cardiotoxicity, which is type 1, dose-dependent, irreversible. It may be acute or delayed, and it may appear even after 10 years from administration of anthracycline. That can damage the myocardium and cause a variety of cardiac effects, including dilated cardiomyopathy, supraventricular tachycardia, myoepicarditis, ECG changes, and even sudden death. Radiation therapy also can have an additive effect on the cardiotoxicity, especially in those who received anthracycline with left-sided breast cancer. Number two, therapy-related myelonoplasm. It is anthracyclines are topoisomerase 2 inhibitors and thought to cause a secondary leukemia and the myelodysplastic syndrome by interfering with ligation after single and double strand breaks. The 5-year rate of acute leukemia after adjuvant breast cancer therapy ranged from 0 to 1.4% in those who received anthracycline in the adjuvant setting. So, which evidence we have that we can depend on for anthracycline de-escalation in treatment of early breast cancer patients? We have the US oncology trial that demonstrated survival benefit was with 4 cycles of TC over 4 cycles of AC in unselected early breast cancer patients, as we can see from the diagrams at diagram A. The 7-year disease-free survival was 81 versus 75 for TC and AC respectively, with a statistically significant difference. Also, as regard to overall survival, it was 87 versus 82% for TC and AC respectively, with a statistically significant difference. This is a summary of unplanned exploratory analysis of disease-free survival and hazard ratio, and the confidence interval favoring TC over EC regardless HER2 status and hormone receptor status and age. In MIND-ACT, a phase 3 trial aimed to test whether patients with high clinical risk and low genomic risk depending on mama print could safely be treated with endocrine therapy alone and avoid chemotherapy. They found a similar disease-free survival and overall survival between non-anthracycline and anthracycline-based regimen. The 5-year disease-free survival was 90.7% versus 88.8%, with no statistically significant difference even in as regard to disease-free survival or overall survival. And we should notice that the trial was not powered initially to demonstrate the superiority of a given chemotherapy regimen over the other. Also, we have the TAILOR-X trial, as Professor Amani said. It was designed initially to demonstrate the non-inferiority of endocrine therapy alone versus chemo and endocrine therapy, especially in those with recurrence score ranging from 11 to 25 based on 21 gene recurrence score, which is oncotype DX. There is a secondary analysis of this trial investigating the clinical outcome in early breast cancer with high 21 gene recurrence score ranging from 26 to 100, which is high recurrence score, assigned to adjuvant chemotherapy plus endocrine therapy. They found a similar invasive disease-free survival and overall survival between different chemotherapy regimens. The invasive disease-free survival was 88.1 versus 87.4. We can see all the numbers are almost identical, with no statistically significant difference between those who received docetaxel cyclophosphamide or anthracycline without a taxane or anthracycline plus taxane. Again, the trial was not powered to demonstrate difference between chemotherapy regimens, and these data should be considered only as exploratory data. There is a very recent pooled analysis of Plan B and Success C trials that investigate the impact of anthracyclines in intermediate and high-risk HER2-negative early breast cancer. They included about 6,000 patients, and they compared disease-free survival and overall survival between intermediate to high-risk HER2-negative early breast cancer. Patients treated with either 6 cycles of TC or anthracycline, then paclitaxel weekly or docetaxel every 3 weeks. And from the diagram, we can see this. There was no statistically significant difference between the two chemotherapy regimens as regard overall survival or disease-free survival. Plus, there was adverse evidence that was significantly higher with anthracycline-based regimen. It was 76.3% versus 70, with a statistically significant difference definitely between the two chemotherapy regimens. This diagram shows the difference in disease-free survival in different subgroup of patients, and we have the only exception here at figure A. The only exception here in survival was for those who have heavy nodal infiltration with lobular tumors who received anthracycline. They achieved a better disease-free survival than those who didn't receive anthracycline. And the other subgroup of patients, there was no statistically significant difference. Even there was a numerical difference, but it wasn't statistically significant. Finally, All the above mentioned information justifies the most recent NCCN guidelines that removed anthracycline-based chemotherapy from the list of preferred options, stating that this regimen could be considered useful only in certain circumstances. In patients with HER2-negative disease candidate to curative chemotherapy, the docetaxel cyclophosphamide combination has been identified as one of the preferred regimens. Thus, the choice of anthracycline-containing regimen should be discussed based on the potential risk and the benefit expected for each specific patient, considering that the higher benefit is expected in patients with heavy nodal infiltration or higher stage tumor. This restricted indication would reduce, of course, the incidence of treatment-related toxicity. Many thanks.